Good afternoon, everyone, and thank you for joining us today. My name is Emily Mooney, and I'm the project lead of the Community Knowledge Program at Wellesley Institute. Before we begin, we wish to acknowledge this land on which Wellesley Institute operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Welcome to our first panel for this new series. The Community Knowledge Program aims to encourage collaborative research and knowledge sharing within the immigrant and refugee serving sector in the Greater Toronto Area. We are funded by the United Way. We work to fill existing gaps in how researchers, policymakers, and community agencies work together to conduct research and apply its findings to frontline work with newcomers. Last year, we brought together a total of 6 panelists from different parts of the immigrant and refugee serving sector to tell us about their experiences and perspectives on research and knowledge mobilization. We heard about misinformation and how it affects newcomer communities, and about community-based approaches to mobilizing research findings and applying them to work with newcomers. Those recordings are available on our YouTube channel and the Community Knowledge Program website. This year, we have more panels for you to attend. This first one today will focus on recent work on the relationship between precarious immigration status and health. The next, to take place over the winter, we'll discuss ways to build successful research partnerships. And the third, in early spring, we'll cover some innovative ways to mobilize research knowledge and make sure it finds its way into practice. Today's topic, precarious immigration status and health, is more relevant by the day. Those in Canada without permanent status are in a kind of limbo, their future uncertain and their options for employment, housing, and lasting social connections quite limited. This uncertainty can have significant impacts on health, and that's what we'll consider today. Before we get to the speakers, I wanted to go through a few housekeeping notes. Please keep in mind that this webinar is being recorded. The video and transcript will be available on our website later this month. If you require subtitles, you can enable live transcription by clicking Live Transcript at the bottom of your screen and selecting Show Subtitle. Please note that the chat function is disabled for this event, but we encourage you to use the Q&A function at the bottom of your screen to participate. As soon as we finish the discussion, a short survey will appear on your screen in your browser. We would appreciate it if you could stay with us until the end to share your feedback, as we will use it to improve our future programming. We're going to start with our panelists' presentations, and then we'll come back together for questions afterwards. We have 3 remarkable panelists that we will hear from today. First, we will hear from Monica Gagnon. Monica Gagnon is a SSHRC-funded doctoral candidate in the Division of Social and Behavioral Health Sciences at the Dalla Lana School of Public Health, the University of Toronto. She's a critical qualitative researcher focusing on the intersections of non-citizenship and access to healthcare. Her work examines negotiating access to care for medically uninsured people in Ontario, in particular, how exclusionary discourses related to citizenship and immigration, such as the discourse of birth tourism, create barriers to access to care. Before moving to Toronto, Monica worked in the area of access to quality healthcare for uninsured and underinsured people in New York City. Second, we will hear from Paglingayen from the Neighbourhood organization. Pinky arrived in Canada in 2004 as a live-in caregiver and organized caregivers and care workers and newcomer women. She's now a settlement counselor working with newcomers by providing direct support through information, referral, and advocacy to assist them in their integration and settlement in the community. Third, we will hear from Syed Hussan, Executive Director of the Migrant Workers Alliance for Change. Hussan is the Executive Director of the Migrant Workers Alliance for Change and serves on the Secretariat of the Migrant Rights Network. The Migrant Workers Alliance for Change is a democratic membership-based organization of migrants. For the last 15 years, Hussan has been part of successful pushes to win rights and dignity for migrants. Looking forward to the discussion today, and let's get started with Monica Gagnon.
Hi, can you hear me?
Yes, thank you.
Okay, great. I'm just going to share my slides. All right, can you see that?
Yes.
Great, thank you. Thank you so much for having me. I'm happy to be here to share the findings from our recent paper on the effects of not having authorized immigration status on health in Canada. And as Emily said, excuse me, I'm a doctoral candidate in social and behavioral health sciences at the University of Toronto. And my dissertation work focuses on access to healthcare for medically uninsured populations in Canada. So I'm here to share what we found in our research about what the academic literature has to say about having precarious immigration status in Canada. As a public health researcher, my focus is on the health impacts in particular, and our research population of interest was people without authorized status. So we didn't focus on precarious status. All versions of precarious status, we really only focused on not having authorized legal status in Canada. So our paper was published last year in the Journal of Immigrant and Minority Health, and our goal with the paper was to update a literature review published by my co-author, Denise Castaldo, and her colleagues in 2010. In that paper, they focused on how being without authorized status in Canada affects people's health, service access, and working conditions. So they reviewed literature from 1999 to 2008, and 10 years later, we wanted to update that research and see what had been learned since then. We used a social determinants of health framework to conceptualize immigration status as a social determinants of health. So I'll just give a brief overview of our methods. Like the 2010 paper, we used a scoping review, literature review methodology, which explores a broad topic and provides a description of the available research. We did this in order to find out what's currently known about the topic and the overall state of research activity. We reviewed literature published over the 10 years since the previous article, so between 2008 and 2018, and we searched in several different databases in order to establish a broad view of the issue from both the social sciences and health science literatures. You can see on the left, on the bottom, our exclusion criteria. We used the WHO's social determinants of health framework to guide our analysis. So we organized our themes under the three main WHO social determinants categories: structural determinants of health, intermediary determinants of health, and impact on equity in health and well-being. So for those who haven't seen it or aren't familiar, this is the WHO social determinants of health framework that they put out in 2010. So you can see it starts on the left with structural determinants and gets more granular as it goes towards the right. And you'll notice that immigration status is not an explicit part of this framework under social conditions. I don't know if you can see my cursor, but here they have social class, gender, ethnicity, and racism, but they don't specifically have immigration status. After screening, we included 33 articles in our literature review. They were published in health and medical, immigration and citizenship, sociology, anthropology, and legal journals. Some articles were relevant to all of Canada, but most were focused on particular regions, specifically Toronto and Montreal. Most of the research came from those cities, and they were mostly qualitative studies. According to the WHO framework, structural determinants refers to the interplay between the socioeconomic political context, structural mechanisms generating social stratification, and the resulting socioeconomic position of individuals. The first finding we categorized as a structural determinant of health was the institutionalization of temporariness. The articles we reviewed showed that it's much easier to get a temporary immigration status than a permanent status in Canada, and there are very limited pathways to citizenship and permanent residency if you have temporary status. Temporariness is produced by immigration laws that favor flexible labor over permanent settlement. The second structural determinant of health we found in the literature was stigmatization. So people without status are often portrayed as morally inferior, criminal, threats to national security, taking advantage of Canada's generosity, not contributing to the system, and not deserving of healthcare and other social services. On the other hand, the discourse of health as a human right is used to support health and healthcare as rights for all people in Canada, not just those with citizenship or permanent residency. Invisibilization refers to people not being counted or documented and therefore not being able to be included in research and policy that might impact their specific healthcare needs. In Canada, there's a dominant idea that healthcare is universal, which contributes to the invisibilization of those without status who can't access care. According to the WHO framework, intermediary determinants of health are the everyday practices and processes that affect health. Under social practices and psychosocial factors, fear of deportation was cited as a major barrier to accessing healthcare and social services. Organizations may ask for identification in order to establish eligibility for services, so people may avoid these organizations. Cost is also a significant reason for healthcare avoidance, given that hospitals may charge people without insurance for services. Living and working conditions were also found to affect health. Many people without status have poor living conditions, experience food insecurity, and have limited work opportunities. In the WHO framework, the healthcare system is characterized as an intermediary determinant of health. Even when people do have access to care through places like community health centers, there are barriers to utilization, which can be financial, logistical, or cultural. Lack of health insurance coverage was highly cited in the literature as a barrier to care because health insurance is directly linked to immigration status in Canada. Though uninsured people may have the option of purchasing private health insurance, it can be expensive. Community health centers and other uninsured clinics may be limited by capacity or catchment areas, and people may lack familiarity with healthcare system, be unable to find providers who will care for them, or be unaware of what services are available and what their rights are. The literature showed that providers in Canada may have mixed feelings about serving people without status. Some may feel ethically obligated to offer emergency care, but not non-emergency care. And caring for people without status was cited as requiring additional unpaid work in many healthcare settings. Evidence on specific health consequences of being without status is extremely limited. Many articles reference a general negative impact on health and well-being without discussing specific health outcomes. The literature did show that people without status have high rates of emergency department visits, maybe because they don't have ways of accessing primary care, and so they don't seek care until their conditions get to an emergency level. They also have mental health issues like stress, weakness, fatigue, depression, anxiety, suicidal thoughts, PTSD, and substance abuse. The research shows that there is lower quality of care for people without status and very limited continuity of care. So in this figure from our paper, we synthesized the structural determinants, which are in the outer ring, social positions, and intermediary determinants affecting the health of people without status in Canada. So depending how the social determinants of health are manifest in everyday life, health consequences may vary, and people without status have unique political, social, and economic circumstances that define their health differently from those with secure immigration statuses. The articles we reviewed made several recommendations. So for the first research, the complexity of migrants' experiences, one area of research need, the health situations and consequences for people without status. Obviously, that was a big gap in the literature. The impact of lack of access to services and lack of opportunities to obtain permanent status. The ways different forms of marginalization are compounded to produce exploitation. And there was also a call for collaborative research beyond academia. Policy recommendations included providing pathways for gaining permanent legal status, because obviously the immigration and health policy areas are intertwined. Upholding the right to health in Canada's policies, addressing disparities in access to care, and ensuring providers are compensated to provide care to people without status. The recommendation for practice was to provide additional education and training for healthcare providers on access to care and health and human rights. So in the 10 years since the original scoping review was published by Denise Castaldo and her colleagues, only 33 papers have been published on the health of people without status in Canada. So there's still a lot to learn about the situation, and more interdisciplinary research is needed by social and health scientists and community partners. While some provinces in Canada offer limited ways of accessing care for people without status, the existence of separate pathways for care perpetuates differential care based on immigration status that contributes to a tiered rather than a universal healthcare system. So a more comprehensive and sustainable solution that doesn't discriminate based on immigration status is needed. Social determinants of health impact everyone's life in Canada, but being without status results in particular forms of deprivation and exploitation that negatively impact health and well-being. The WHO framework doesn't highlight immigration status as a determinant of health, even though lack of status affects millions of people around the world. Given all of the health impacts of being without status found in the academic literature, we think that immigration status should be considered a social determinant of health. So thank you very much for your attention, and I look forward to our discussion.
Okay, thank you very much, Monica. That was very informative, and I'm sure it will provide a lot of material for questions later in the session. I'd like to introduce now Paglingayen from the Neighbourhood organization, who will speak about her own work on the front lines with people with precarious or no status in Canada. Panky, over to you.
Hi, everyone. Good afternoon. Thank you for having me here today. As Emily already mentioned, I was a caregiver, live-in caregiver before, and I arrived here in 2004. Just a brief background and history of the caregiving pathway to permanent resident. When I arrived here, I was under the live-in caregiver program, or they call it LCP. So during that time, there's like 3 years to complete your 24 months before you can apply for PR. But during that time, when I was still in the program, I lost my status here because my employer had to release me because I was pregnant. So from there, you can tell right away like the health impact of having no status, or having like a little like how do you call that, little status, I would say, because it's not permanent yet. So that was like a very difficult situation, because there's once I lost my status here, I don't have any way to renew my health card. So that means no health care, no prenatal care, no nothing to make sure that I am healthy and my baby is healthy once I deliver the baby. So during this time, the community responded to the needs of many caregivers, because it wasn't just me who's experiencing the same situation. It may not be about pregnancy, but a lot of women that I've met here in Toronto, most of them have, how do you call that, terminal illnesses, especially cancer. So as I mentioned, that the community responded, unions responded to help the caregiving community be highlighted in their stories and voices, to make sure that we will have like a sure pathway to permanent residency here. Because if you have how do you call that, a terminal illness, you will be deemed inadmissible when you apply for permanent resident here in Canada. So that means that you will not just lose your status, but you will be deported once the decision is made. So the person that I will talk briefly here in the history, the person that I've met during the time that we are campaigning for the removal of the second medical was Juana Tejada. She was a cancer patient. She succumbed to her cancer during, it's very symbolic because she passed away during the Women's Day. But her legacy left us with the Juana Tejada law, where the second medical for many PR applicants were removed. So we were happy that, you know, this will no longer be, the health condition of many care workers will no longer be seen as a, how do you call that, as a reason for the immigration to refuse our application. And after that, there's so many other like reforms that happened. But looking at the reforms that happened, especially in 2010, when the Juana Tejada law was there to assist many care workers who are applying for PR. What happened was, after giving us this, you know, this reform, what happened was that there was a backlog, like a delay, not just for the decision making in the permanent resident applications, but also for the open work permit and even the regular work permit that we are trying to extend to maintain our status here in Canada. So what happened was, during that time, I remember the longest processing time for work permit was 18 months. So I was no longer in the program at that time. I'm already a permanent resident here, but I still continue to work with many care workers at that time because they have no way of knowing where to turn. So I usually refer them to nonprofit agencies like TNO and other groups that actually help them advocate for themselves and you know, help in creating that space for us to talk about the issues and help reform the program, the LCP. So during that time, the 18 months, I remember writing so many letters for care workers so they can how do you call that, apply for the renewal of their health card, because many of them actually stop their treatments and even like the screening or health screening that they should have done when they have their health cards. So that's what's happening. So looking back, I felt happy before when I heard the news that, oh, this and that reforms happening. It will benefit the care giver community. But unfortunately, it's I would say it's meaningless because it's how do you call that? It became more difficult for many caregivers to access their permanent residency here in Canada because of the backlog. So that's when I went back to school, study here in college, and fortunately I was hired as a settlement worker specifically for caregivers. So I thought I know a lot already about the caregivers issues, but unfortunately I've seen more issues after issues that is so overwhelming. Not just for me, probably for other people, individuals who advocated for many of our clients, even the agency that I work for. That's why what I did before is to always be present in many town hall meetings, collaborated with many organizations, individuals, communities, to help highlight these issues that the community is facing, the community of caregivers facing. So we are thankful that there's a like massive response from a lot of people that help us how do you call that, not just for the campaign but also winning all those campaigns. So with the little victory that we have, I would say little, because whenever they give us something, the more that our how do you call that, our situation or immigration status became like precarious, the more that a lot of workers are anxious about their status here in Canada. So I would just say that I remember when I was hired here, my first ever, how do you call that, client and campaign that I supported was Let Kenneth Stay. He's a child of a caregiver who passed away because of cancer. And we were trying our best to help and support him to become a permanent resident here, because Edna, that's the name of the mother, left him in the Philippines when he was just 5 years old. So imagine, like, 5 years old, and now he arrived here as a teenager. He only knows that this person is his mother. They don't have that bond or relationship as, you know, as parent and child that actually exists to many families. So from there, you can tell right away that there's a I would say breakdown in the family relationship. So Kenneth stayed here, but many others followed. There's Lian, there's Saniel Herente, there's Sana Grace Balance, there's Judeline Grace and Edward John. Sorry. I feel that it's important to say their name here, because these are the people that I've seen as clients here. They're not numbers to me, but they have like special place in my heart. That's why I supported the campaigns, write letters, and everything that I can do to help them maintain their status here and become permanent residents. And I'm so thankful, as of today, all of these children are now citizens here in Canada. In 2014, we engaged again to make sure that the government will respond to our call for the fast track of the, how do you call that, of the applications of the caregivers, because a lot of them are losing their time, you know, time in terms of like spending with their families, because they already have terminal illnesses. And after that, yes, there's some changes. The government responded, the immigration is responded. They created 2 pilot programs, but is it really, you know, a meaningful change, fundamental change for many care workers? For some, they will say it's yes, because the processing time was reduced. But for many, it's still like a no, because you can tell that they created more layers of difficulties for many care workers, like the language requirements, the education requirements, and some of them are in limbo because when they arrive here in Canada, they are in the so-called transition from one pathway to another, making it difficult for them to apply for permanent residence. So until now, I have so many of those clients who are still on work permits. They've been here more than 10 years, but unfortunately, they're not able to apply for permanent residence. They've studied here, they tried their best to become permanent residents here, but come to think of it, the 2 years requirements, which is 24 months, should be sufficient for them to become permanent residents here. So what happens was a lot of them actually lost their chances to bring their families here. So a lot of them are alone here in Canada. And just this year, I actually assisted 3 of them to apply for visitor's visa for some of their family members, because again, these 3 care workers are facing, you know, terminal illnesses. So one of them actually passed away, but I'm thankful that the family member arrived here on time before it happened. But again, when I'm doing any assessment with my clients, I could tell that just like what the research says in Monica's presentation, I find that access to health has been very difficult for them. A lot of them doesn't have family physicians. They don't have access to like healthy foods, even if some of them live in their employers. And if they live in their employers, even if they have access to like nutritious foods, chances are they will have emotional or mental health issues because of the kind of job that they're doing. They're tied to one employer, and they're not allowed to do certain things. They don't have the same freedom as permanent residents. That's why they're so scared. They do whatever to complete their 24 months and stay with their employers without knowing that they can actually do something, with their situation. But because of what they hear also from previous experience of their friends, they opt to stay in that difficult situations. So during the pandemic, it became more difficult for many of them because it's not just how do you call that, food insecurity or I would say lack of access to healthcare. But I've seen that a lot of them actually lost their status because a lot of, for example, the Philippine consulate or other embassies were closed, so they cannot renew their or extend their work permits. So the more that they cannot access a lot of things because of losing their status here, um, they cannot renew their health card again. Same thing that happened to me because they don't have the proper documents. Even if they're saying that, oh, you can extend it because Ontario said this and that even if your work permit or your health card is expired, you can still access your doctor. But the problem is they don't have family physicians in the first place. So it's difficult to even access like how do you call that, um, walk-in clinics because they would ask them to pay, and because of losing job, most of them lost their job, so that means they cannot even afford to pay for that. So a lot of them ended up like really badly sick during that time. And it's so funny because they were not allowed to have days off because the employers were saying that, oh, you will end up like bringing virus here. But what I've seen, a lot of them got really sick because their employers went somewhere. Have clients who got TB, got COVID, and a few of them were even in, how do you call that, ICU during that time. So you can tell right away that this is the result of having tied to one employer because of the work permit. That's the condition of their work permits. And not having the permanent resident status here means that they always have the least access to many services. For example, even for us, our services are free, but for some they're scared because especially the ones who already lost their status because they fear that they may get reported or something like that. So those are the things that these care workers are facing. Actually, even other migrant workers, even students, I've seen that, because I have a lot of clients from those temporary like resident streams. So I would say that what shall we take away from the studies that was presented and my experience as a care worker myself and now as a settlement worker is that even in the past and now in the present, improvement in the status of many care workers and migrants, we as a community, as Canadians, or as like human, we should always keep on pushing for fundamental changes that we want to see, because these care workers and other migrant workers are potential citizens of Canada. And I would say that many care workers, especially Filipinos, I would say that we are being funneled to the caregiving, how they call that, positions or employments. We are your nurses. We are your personal support workers. We are the special needs assistants in school. We are the ECEs or ECAs at school. And even like who's, how they call that, doing the cleaning jobs and everything. Most of these are coming from the caregiver community. So if we look at those situations, we should think of this group not just like, oh, they're temporary workers here. No, we should think of them first of all as humans like us. So whatever human rights we have, they should, how do you call that, also have the same rights as we have as citizens and permanent residents here, because they are not second-class citizens. They are also parents. They are children of their parents. They have families. So I would say that for those who are listening, that we should continue to just not have a second look or whatever, but look at the situation. How can we help? How can we assist, people who are already working on this? How can these studies or research can be used to impact changes for the programs of different like immigration, how they call that, pathways. Yeah. So I will end here, and thank you so much for listening. Yeah.
Thank you so much, Pinky, for a really passionate and very thought-provoking discussion of what you have seen in your own lived experience and in the experiences of your clients. Thank you. And to address some of what Pinky was talking about with regularization of status, I'd like to welcome Hussan, who will speak now about his experiences with the Migrant Workers Alliance for Change.
Hi, everyone. Thank you so much for having me. I see a whole bunch of people and names that I know, many of you who are have been in this work for a long time. So I'm very much excited about the conversation that will follow. I'm going to do a bit of overview of the immigration system and our work very briefly, and end on regularization in the 7 minutes that I have, and then hopefully we can really dig into the rest of it in our conversation. So hopefully I can get this thing to move. Here we go. Okay, so of course, I want to begin by acknowledging that we are in Indigenous lands, and it's important for us to do that because when we're talking about immigration laws and policies, they are in fact laws and policies that are impositions, right? The first settlers did not ask for work permits or permanent residency or citizenship. And if we believe, as many of us are acknowledging, that these are Indigenous lands, then that means that Canada's immigration laws, or most laws, or the laws of Canada, are those of a settler colony. So we have to ask ourselves, how do we justify and reckon with these things? For us, we want to be very clear that we are not fighting for citizenship. We're fighting for access to rights that citizenship provides. And I'll talk more about that as I go along, and that we see ourselves in solidarity with Indigenous struggles for self-determination. When we're talking about migration, it's crucial to zoom out and look at the rest of the planet, right? So we are talking about the kind of massive exploitation of people and a massive consolidation of wealth that is taking place in an unimaginably high rate. Right. Just to give you a sense, during the COVID-19 pandemic, there was a new billionaire that was created every 33 hours. And during approximately the same amount of time, 1 million people fell into extreme poverty. So to give you a sense, that would be as if the entire population of Canada fell into extreme poverty within 41 days, right? We are talking about this massive separation between the rich and the poor at unheard of levels. And that's happening because of the decisions being made in places like Canada, which is one of the few richest countries in the world. And so everything we talk about has to be within that conversation. So whether we talk about climate crisis, war, poverty, all of these affect working class people in the global south much worse. And then Canada profits from these processes, whether it is the fact that Canada is one of the largest per capita emitters of greenhouse gas emissions, or is the world's, seventh largest exporter of armaments causing war, or whether it is as place where 2/3 of the people that 2/3 of the world's mining corporations are headquartered here. The process of impoverishing people, which is central to the process of displacement, is produced in this place called Canada. Now, while this is happening around the world, we know that as a result of this, there are, if you took all of the migrants in the world today and you put them in a single country, it would be the world's 5th largest country. That is how many migrants and displaced people there are in the world. And most migrants and displaced people are actually in the global south. They're not actually coming to the global north. And this is crucial to understand because a lot of the debate around access to permanent residency is, for example, the context of Canada is like they'll come and take over our healthcare, while most migration is actually south-south. Now, here in Canada, bosses have 2 dilemmas, right? So the one is that workers are aging, and we see this all the time. So, more people are exiting the Canadian economy than there are people entering it. And so workers are aging. At the same time, bosses don't want to share profits with their workers. They want to make money, but they don't want to share them. And so in this context, there has been the creation of, and Pinky talked about this in the context of the care worker program. I want to just very quickly touch on some of the other ones. That by denying permanent residency to hundreds of thousands, actually millions of people, it's an intentional project of bringing in workers, but denying them rights. And so it's not a failure of policy or a gap in policy that healthcare is not accessible to undocumented people or other migrants, but rather it is intentional. It's intentional because that is the mechanism through which it is possible to keep people exploitable. Now, over the last 20 years, we have seen a 740% increase in work permits, right? So there were approximately 60,000 work permits issued in the year 2000 and close to 600,000 in 2021. These are just work permits that we're talking about, which is to say, to give you a sense, it is as if, Canada's population in the year 2000 was 30 million. So this rate of growth would look like approximately as if there were suddenly, 300 million people in Canada over a span of 20 years. It is this, so simultaneous to this global consolidation of wealth, the doubling of people who've been displaced. So in the last 10 years ago, there were 40 million people displaced. Now it's 80. So we're seeing these massive escalation of displacement, wealth, and simultaneously temporariness in the context, not just of Canada, but almost every country in the global north, right? Now, that's actually not even the largest section of the migrant workforce. In fact, the largest section of the migrant workforce is international students. Now, some of you may think, well, international students are here just to study, but that's not true. There are almost 700,000 people entering the country on study permits. Maybe 20 or 30,000 of them will actually get permanent residence. The rest of them will work here for a few years, often in low wage economies as gig workers, delivery workers, construction workers, cleaners, and they'll be kicked out of the country. Right. So we can see that actually, care workers and agricultural workers and farm workers are now the smallest part of the temporary workforce. At the same time, it's important to understand another group, refugee claimants. We need to understand that refugee claimants are also, in fact, migrant workers. 40% of refugee claimants will be denied, which is to say that they'll come here, work for a few years in low wage, exploitable work, often also excluded from essential services like healthcare, depending on where they are in the process, and then eventually will be kicked out, right? And so as a result of this, sorry, my image has disappeared. Okay, sorry. So there are 500,000 undocumented people and rising. So this is the community Monica was referring to. So as people are not able to get permanent resident status when they're migrant workers, care workers, are refugees, international students, they become undocumented. So if you think about this, in total, there are 1 in 23 people in the country are migrants with different immigration status, all without permanent resident status, many of whom are excluded from basic labor rights and protections, as well as essential services like universal healthcare, people needing to pay if they are on study permits, or you have to work for 3 to 6 months to show that you're full-time employed, and then you're able to enter into get access to healthcare. Or if you're undocumented, you have no access. So in this way, the denial of permanent resident status to this massive number of people ensures that there is a denial of basic rights. And what it is a human rights catastrophe. We heard from Pinky talking about care workers, but so I want to bring in a couple of more groups into the conversation. I mean, on your screen, you see these 3 men who died in the first few months of COVID-19 while working in farms. In fact, for the first 4 months of the pandemic being declared in Ontario, you were 5 times more likely to get COVID-19 if you're an agricultural worker rather than if you were a healthcare worker, right? So we have seen this massive human rights catastrophe that has taken place, but it's not just that. If we look at our system around long-term care, when COVID-19 went on a rampage, who is it that remained and continued to work there? It was refugee claimants and undocumented people. So not only are migrants being denied healthcare, but as Pinky spoke about in the context of nursing, they're also healthcare workers themselves, and often the last line or the first line, apologies, of at the crisis when healthcare is in crisis. Now, I started with this. I want to sort of reiterate it. Permanent resident status is the mechanism through which all of their rights are accessed. So that's what we're talking about. We're talking about the right to access the ability to access basic rights. And so, as Monica spoke about it, status becomes the dividing line. If you have it, you have access to rights, and if you don't, you don't. And so for us, absolutely, we need to think about status as one of the mechanisms in which we understand, like racism, like patriarchy, as one of the organizing systems of the world today. Now, I work at the Migrant Workers Alliance for Change, which is a membership-based organization of farm workers, domestic workers, and healthcare workers, and current and former international students, as well as workers in fisheries. So what does it mean for us to be membership-based? What it means is that we are creating and supporting workers to create their own organizations, whether it is at workplaces or on farms, at university campuses, in communities, online and offline. And I say this because it's crucial. Migrants are not simply the recipients of the disaster. They're not being acted upon, but are rather organizing and fighting back. We have hundreds of members, tens of thousands in our broader network of migrants who are collectively organizing and taking action. And this is producing incredible results. Just since March of 2020, we have won through collective action, access to vaccines for undocumented people. We have stopped 100,000 deportations and gotten that many postgraduate work permits issued. 500,000 students can work without restrictions. 83,000 new low-wage workers were able to access PR that they wouldn't have otherwise. And probably, as many of you know, in Ontario today, even if you are uninsured, there is a Ministry of Health directive that allows you to access emergency healthcare or in-hospital healthcare. And we have been promised a lot more. Right now, we are in this moment where the federal government could be pushed to creating a regularization program. A regularization program is one in which everyone in the country, everyone who's undocumented, is able to get permanent resident status. So I want you to just spend the next 3 minutes watching this video from undocumented people themselves, speaking about what it is that they are facing. So I will I will play this video right now. I just want to make sure that it is allowing you to, sorry, apologies. Just want to make sure that the audio is shared too. Okay, here we go.
I almost had a heart attack because of my status. I can't go back to where I came from. They do not believe in same-sex partnership. They will kill me.
J'ai quitté l'Algérie, moi et ma mère, parce que mon frère a été assassiné par la gendarmerie nationale.
Especially because I have 2 kids, and as a woman, it's very scary to be living in Mexico right now.
I came to Canada as a temporary foreign worker, and I am now undocumented.
I came here on a farm working permit. I've been here 1 year now.
As a live-in caregiver to help as well the elderly. That's why I'm here.
Me vine porque se vino mi familia para acá. Yo llegué a los 46 años y tengo 79.
You're intimidated at work. Your co-workers do not treat you the same.
I told her I wasn't feeling well. I was feeling a lot of pain in my back and my knee. Told her I want to go to the doctor. She said to me that I just got here. How can I be sick?
It started when I give him a bath. He wants to grab my breast. But one day, I tell to my agency that he's doing to me, but they are not listening.
Also try to raise the rent like $300, like from one day to another. You don't have any ID, so you will have to like take it or move to another place, blah blah blah.
L'opération nous a coûté $7,000. Et cette période-là, on avait rien. On a tout vendu à la maison.
She's mom, like, am I gonna be able to go to high school or no?
I pay taxes. I have a full-time job and part-time job, but I don't have the access to healthcare and other services that the Canadian gets.
Je vis ici au Canada. Je contribue à la société canadienne.
Los desfiles más grandes del orgullo gay ayudaba a hacer los carruajes, las flores y todos los arreglos.
I want to work hard for my family and the community, but for that I need a legal status.
If I get my PR, I would go back to school and upgrade to being a doctor.
Avoir la résidence permanente pour moi, c'est d'avoir un permis de travail pour travailler dignement. C'est avoir un RAMQ pour se soigner.
Quería, por empezar, sería la mujer más feliz del mundo.
C'est d'avoir une pièce d'identité et de circuler sans peur dans un bus.
I could see my kids, my family.
Me sentiría libre, ¿no? En una palabra, libre.
I would be free.
A fair society means
Equal right.
Pour toutes et tous.
Y eso significa estatus permanente
Full and permanent.
Immigration status for all.
for all.
para todos.
Hussan, you're muted.
Sorry, I'm here. So I want to end with just to, that healthcare workers, educators, researchers are joining in this fight. Earlier in October, over 1,000 healthcare workers jointly signed a letter that has been issued calling for full and permanent immigration status for all. Right now, educators, and that means if you're a researcher and a professor, a teacher of all kinds, are being invited to sign this letter calling for the regularization of undocumented migrants status for all and education for all. So I will share those links in the Q&A function so that people have access to it. So now is a moment in which we can collectively deal with this historic injustice. We have the ability to ensure full and permanent immigration status for every undocumented person and potentially every temporary foreign worker, every international student, if we unite and fight. The federal cabinet is supposed to hear about this year. Right, we have less than 8 weeks left in this year. We need to organize and speak up at every possible place that we are. Right now, we're talking about how undocumented status makes it impossible for people, or migrant status makes it impossible for people to access healthcare. It doesn't have to be this way. And so if there has ever been a moment to take collective action, it's now. So I urge you to get involved, or go to statusforall.ca, sign petitions, come to protests, make phone calls, so that we can make sure that the maximum number of people are regularized. And that's all for me. Thank you.
Right. Thank you very much, Hussan. excellent presentation, and again, it had quite a bit of impact to hear directly from the people who are affected by the lack of status and the impacts that it can have on healthcare. So what I'm hearing from this is that while Monica presented information about the structural barriers to health for people with precarious or no status, we've heard the effects and the impacts of some of those barriers, and we've also heard from Hussan about ways to begin addressing them. I'd like to start the Q&A session now, and I'd like to begin the Q&A session by bringing up a question. And I think any of you would be able to answer it, or I'd like to hear the perspectives of each of you on it. How do we translate the research, for example, that Monica presented? How do we translate that into practice? I'll give you a moment to think about it. Like, how do we apply the information about the impacts on mental health, on physical health? We've heard Pinky present a lot about the actions that she has taken. Hussan talked about the actions that his alliance has taken. What else do you see as things that the average settlement worker or researcher could take from research and apply to practice?
I think the most effective thing about Monica and co.'s study has been is that it has become, one more way for us to show the federal government that they need to push for a regularization program. It was one of the studies that is cited in our memo on regularization, also one of the studies that's cited in that letter that is written by healthcare workers. So I think, research is in the service of organizing. And as long as it is, closely tied to and furthering the demands that have been articulated by those who are most directly affected, it is effective. So I think the, basic premise of research needs to be in that way. And I think for, people who are doing one-on-one client services and support, or like settlement workers, we need to be able to move ourselves from treating people as individuals to treating people as collectives, right? And so whether an organization can do it on its own, that's one thing, but if not, to refer to groups, so when Pinky was at TNO, her clients would be referred to the Caregivers Action Center, which is a part of the Migrant Workers Alliance. And so that way there was a space for people not just to deal with the immediate crisis, but be part of democratic decision-making spaces where they could actually formulate the solutions and then fight to have them implemented.
Okay, thank you. Any other thoughts? Thank you, you're on mute.
I have experience in the past. After we've done the research, we've done a knowledge exchange using or employing the actual, how do you call that, participants in the research. In that way, because we were the one who actually experienced, one of that researchers from Access Alliance, we created videos, campaigns, and we actually mobilized the community members to help us with different campaigns. It was a provincial one for the minimum wage, and also like that this kind of works, the bad jobs that we are calling them, are making us sick. So I've seen a lot of successes in doing such thing, that when we're putting the faces and the voices of the people who actually experience these issues, it is more impactful in terms of like creating solutions to the issues. So I would say like creative, how do you call that, knowledge exchange, like what we did before. So yeah.
Yeah, I agree with what the other two panelists have said, and I think especially from an academic position, really needing to work on some of the findings that we found in the literature review, which is more collaborative research. And, you know, when we think about where most health research funding comes from, it's not really community. There's not a lot of funding for community activities. And so, you know, thinking about the whole structure of how research is produced and getting more funding towards these types of things. As you saw, we did research, you know, covering 10 years since the previous scoping review was published, which is still cited. You know, the Magalhaes and Gastaldo and Carrasco article is still cited a lot because there's just not a lot that people can draw on in their campaigns, et cetera, about these issues. And so, you know, pushing funding and research activities towards things that can actually get more issues in the political spotlight.
Okay, thank you. Yeah.
I want to share, you know, one of the sort of core organizing strategies that we use is kind of, you know, what we refer to as organizing reports. So reports that are written for the purposes of a campaign. So during COVID-19, for example, we wrote something called Unheeded Warnings when farm workers were affected. We wrote another report around care workers that was called Behind Closed Doors. So we often, in the midst of a campaign, we're going to write a report on regularization and status. We'll create reports based on surveys, focus groups, discussions that are designed completely with the objective of policy changes. And are very successful in that. You know, this is a model that many similar organizations like ours use because they provide a way to sort of put forward an entire agenda of changes. So when it was, you know, around labor law, we can put in an entire agenda of labor law reform or a new vision of immigration policy, etc. So I think it's also important for researchers to know that, you know, we are doing our own research often. And producing knowledge that is years in advance of other processes because it's just so much quicker. You know, I'm not going through an ethics approval. I can have a meeting with 5 people, write it down, publish it tomorrow. And I think that those are, you know, strategic initiatives to get responses are very, very useful in terms of doing research in this action, you know, with a focus on action.
That's a very important point. Thank you. And this is something that has come up for us in the needs assessments that we did at Wellesley Institute last year about how there is such a gap in the literature, and when we get people working collaboratively and producing gray literature, it can have a much quicker impact on practice, but it often isn't taken as seriously as it might be if it were in a peer-reviewed academic journal. So I think building some trust among academics and community organizations that the research that's coming out of the community organizations can be very informative and can help build academic studies as well. Okay, I have another question that has come in from one of the audience members. I'd like said, thanks to all the panelists. Is there a collaborative effort by organizations assisting and advocating for temporary workers to advocate for legal and policy changes at the federal level? It will be helpful to involve law societies, legal clinics, MPs and MPPs, and so forth.
So we, in the end of 2018, created something called the Migrant Rights Network. It is a coalition of 40 organizations in 8 provinces that are primarily migrant-led organizations. And for us, this is really crucial to ensure that nothing about us without us. And this has been the primary organizing force, which has resulted in all of these immigration changes that have taken place over the last few years. And so I urge people to go to statusforall.ca to sign that petition and be engaged in the work. You can see who's involved there. And it is, the only cross-country migrant-led organization that deals with all issues around non-permanent residents. So that means temporary foreign workers, but also international students, undocumented people, refugee claimants. And we are, the ones who are been taking on most recently this regularization campaign. So that's an organization everyone's invited to learn and join with. If you are a migrant-led organization, you can participate. We'll have regular ally meetings for organizational allies. And I'm going to share also, I'm not, if you go to that website, statusforall.ca, it's hard to drop links here, but we are currently asking for letters of support from organizations, which is a way of getting involved in the work, which is to write. Let me see how I can, maybe I'll respond to that question also. Here, this will hopefully help people to just see all the organizations that have been writing letters, and there are template letters people can use to join in.
Okay, thank you. It's very impressive to hear about all the successes that the Migrant Rights Network has been having. It's very encouraging. It would be interesting to build some more connections among academic researchers and the migrant-led organizations to produce even more evidence to take to the policymakers to make sure that status is regularized and that people have access to basic rights. Okay, thank you. Another question. This one is a lot more on a practical level. What can a pregnant student do when she is told that she has to pay for her pregnancy care, her delivery and postnatal care because her pregnancy is a pre-existing condition?
As Hussan mentioned, all services for medically necessary services right now, because of the ministry directive for the pandemic, should not be paid for. So if the delivery is in a hospital, everyone should be able to access that with or without a health card. In terms of outpatient care, those things might have to be provided through a CHC, or you might want to see what's available in the catchment area. But I want to highlight the work of the Health Network on Uninsured Clients, because they're navigating these issues all the time, and they have connections with hospitals, and they're used to making sure people's rights are upheld when hospitals put up financial barriers to people being able to get care that they are entitled to. So I would encourage you to connect with them, the Health Network on Uninsured Clients. They have a lot of resources and can direct you to hopefully finding care.
I also dropped in a link to, we run hotlines for migrants in different categories, including international students all across the country. It's a 24 hours multilingual hotline available on WhatsApp as well as the regular phone. So I just dropped the link. We also have a hotline for farm workers, care workers, and fishery workers in English, in Spanish, Korean, many languages. So that person can also just get in touch with the hotline, answer some basic questions, and will be connected to resources and services. Yeah.
Yeah, same with what Monica said. I usually refer them to community health centers near where the clients live. So yeah.
Sorry, I also should mention that in Ontario, midwives have a mandate to care for uninsured populations. So their funding stream is parallel to OHIP. It's not through OHIP. And so anyone who's uninsured should be able, assuming there's capacity, to be able to get midwifery care, and, may opt for a home birth if they're low risk pregnancy to avoid hospital fees. So that should be an option if you want to look into midwifery clinics near the client.
Okay, that's very helpful. Thank you. So one thing that came up was how the access to healthcare changed during the pandemic. And I think we'd be interested in hearing a bit more about how these specific pandemic-related changes have supported people and whether these changes are being rolled back. Will the mandate to provide emergency care regardless of status continue? And is there any plan for it to change in the future? And if so, who's going to pick up the slack?
Maybe I can quickly respond. Is there, are you wanting to focus just on Ontario?
Yes.
Okay, cool. So maybe I'll kind of try to space out like what it is we're talking about. So, you know, when we talk about access to healthcare, there's always kind of like what are the laws and policy, like what is de facto available and what is available in law and policy. And so what we're seeing is, you know, throughout COVID-19, things like testing, sure, was eventually available to everyone regardless of status. But if you're a farm worker, you need permission to leave the farm. You needed transportation to leave the farm. You needed to be able to get to a health site and then be able to speak in the language there. Right. Similarly, yes, you have access to healthcare, but as many services move to so-called virtual healthcare, so on the phone and online, if you don't speak the language, you don't have that technology, you don't have access to healthcare. Similarly, there are various kinds of access to health, but in terms of the Ministry of Health directive that has come down, you know, our organization has gotten hundreds of thousands of dollars back from hospitals because hospitals charged people even though they were not supposed to. So despite the fact that the Ministry of Health directive is there, many hospitals will charge people if they can get away with it. So, but in any case, the Ministry of Health directive is going to stay as long as we fight for it. I think that's really, really crucial for all of us to be able to say is that we need, you know, a few months ago, a letter was signed by over 1,000 healthcare practitioners that was issued from Ontario saying we will defend this. And at that time, we knew for a fact that the government of Ontario was considering withdrawing the directive, but as a result of the political pressure and the outcry, it has been reinstituted. I would say the number one way to ensure the Ministry of Health directive remains in place is for us to try to get as many people as possible to access it and then share those positive stories. And you know, it's harder to take away something that everyone believes is sort of like normal. So I think we are in an interesting moment at this point. You know, the latest, we continue to hear rumors and threats of it being revoked, but I think as long as we are fighting for it, it can stay.
Okay, thank you. I'm afraid Pinky has had to leave to address something else, but we are still open to questions for the two of you, and you've been providing wonderful answers. Thank you. Another question is, what would you like for academics to learn from the community about precarious status and health? And what are the barriers to this kind of learning? What do you think academics should know?
As an academic, I will punt that question.
Oh, I was hoping you'd answer it, please. I'm like, everything? I don't know.
Yeah, I agree. Everything. I mean, I think that, you know, students in academia have to come up with research, right? And so, but I think I find that there's a disconnect between like what needs to be researched and what gets researched, you know, and people are always asking for evidence to support activism. And, you know, especially right now, what we're talking about with the directives, like, obviously it would be great if we could show some sort of evidence that, you know, this has really helped people's health outcomes, right? But that long-term research takes a long time to produce. So, you know, we're talking about things like gray literature, putting out reports, putting out stories. So yeah, no, I think as much as possible, if academics can embed themselves in places where there's need for evidence, that would be ideal. But I don't think we do a great job of it all the time.
I think maybe one thing that I would say is sort of maybe, you know, a note of caution. We are asked to join research initiatives, 4 times a month at least, right? So in addition, and then MA students, PhD students, but even undergrad students who get assigned our work in classes, dozens and dozens of requests. We actually have this very now formal response. We don't even read if you get in touch with us saying, I want to research. We have this like response with 5 questions, like, who thought this was a good idea? What migrants are calling for it? How will they be included before we even participate? Because we're overwhelmed by people reaching out. And I think, this happened like in COVID-19 started, all the focus on farm workers, everyone was interested. Then healthcare workers in long-term care, suddenly everyone's interested. So I do want to say that while, while it's important, it's essential that those who are directly affected are the ones leading. Sometimes the timelines just don't match up, right? Unless there is a real meaningful result of research to our work, we can't really participate. It's just too much effort. And often, when we're like, well, what's the result of this? It's like, well, this is a 5-year shark study. At the end of it, it will get published. It's like, cool story. But like, it's not our timeline. Or, I'm working on my whatever dissertation, or my article is going to go through a 1-year peer review process, et cetera, et cetera. So just thinking through how to, like, what is the effectiveness for us in terms of like, which is, I can't go to our members, who work, average 16 hours a day, 6 days a week, to be like, now do this interview in return for whatever, $25 Tim Hortons card or something, whatever has been announced. And they'll be like, well, what will it accomplish? And 9 out of 10, the answer is nothing. It will add to the body of knowledge, et cetera, but like folks don't frankly care or understand or want to understand. So what I would say is, like, for people who are wanting to research migrant issues, so recently, for example, we were asked to like participate in a survey with care workers, and we were sent the survey and it had 63 questions. Who is filling out a 60-question survey? So I think what I would say to people is like to understand that these are low-wage, racialized, working class people who have their own interests and objectives, who are fighting for their own rights. And they're not simply respondents, informants, sort of these passive subjects, but are rather have their own desires and intentions. And so you need to come to us before you start putting in your funding application, or not 2 days before your funding application, be like, can you please sign on this letter? If we get money, we'll talk more. Like we need actual ethical relations, which are quite difficult, in my experience, to have with people.
Thank you. This definitely echoes a lot of what came up in the needs assessment. There was the leader of a very large service organization who stated that they just don't do research partnerships because so many researchers just parachute in and have all their questions prepared. And like you said, they don't provide any information about the benefit of the research, or it's just the $25 gift card from Tim Hortons, and they never are heard from again. Yeah, so for the screening questions that you mentioned, Hussan, I'm seeing some interest about that. And as I'm listening to everything that everyone is saying, and you're mentioning some great resources, so we will be putting a list of the resources up on the Community Knowledge Program website. And we will share that link with everyone who has participated today so that you can find, for example, the Status for All website. And Hussan, if you would be willing to share those screening questions, I think they would be really useful for a lot of people who are in a similar boat to the one that you're in.
I mean, I just dropped the link to Spring, who had asked the question. If folks want to look for the link, it's it's like an online link, which is what we send to people now. But I'll quickly read them for folks who may be interested. It simply says, what is your relationship to migrant workers and migrant justice? How have you supported migrants in the past? And are you committed to doing so in the future, regardless of this current project? Second question is, how have migrant workers involved in the creation of this project? Have migrant worker organizations given you direction that your project is necessary and timely? How does your project fit in with the public campaigns and demands of migrant workers already underway? Number 3, how will this project further the struggle for migrant justice? Are there measurable and achievable goals that you've set out for this work that will further campaign demands set out by migrant workers themselves? Number 4, how will you support migrant workers? Have you considered how you will ensure anonymity for migrant workers where necessary? Have you considered how your project may re-traumatize workers or staff, and what supports you've put in place should that happen? Will you be compensating workers or their organizations for their time?
These are great. They sound a lot like the kinds of questions that would go through a research ethics board. But as you were saying, with a lot of the more gray literature research, they wouldn't necessarily have to go through the research ethics board, but they're still very useful questions for pretty much anyone wanting to work with an organization. And I think they could be easily tailored to other areas, not just migrant workers, but for example, older adults, immigrants, or specific populations. These are very, very helpful. Thank you.
Yeah, and we actually adapted this from Maggie's, which developed these questions for sex workers. And so we organize with migrant sex workers through Butterfly, the Asian Migrant Sex Worker Network, and also connected through Maggie's about it. And so you'll see if you click the link that we have referenced where we have taken the questions from.
Fantastic.
Okay. I just want to say that this conversation is making me think. I used to work in a healthcare organization, and we would get the same thing, just, oh, can we test our new, device on your patients, or, so I just want to, I know that the timelines in academia are very cumbersome, but I just want to make a note of support for the research ethics process, because I think that is very important, especially when doing health research. So, it just speaks to the sometimes long timelines that research can have, especially if it's ethical research, making sure that the processes the understudy are thought through. And, the research ethics process can help prevent these sort of like, oh, I need a population to study my theory about, or something. I think that's an important tension between the amount of time it can take to do ethical research, but also like the need for research for advocacy. So it's something I'm thinking about. I don't have an answer.
That is definitely a thorny question. Yeah. And what you're saying also about the timelines of academic research versus the needs of the community agencies also came up in our needs assessment, talking about how useful it would be for academics, like the results of academic studies, to come out around the time of funding cycles for community groups. So, for example, if a study comes out in January or February and everybody's writing their applications for the next however many years of funding in March, they can draw on that knowledge to provide evidence for the kinds of programs and services that they would like to provide. Okay. We're getting fairly close to the end. If there's anything that anyone else would like to ask, or anything that you'd like to hear about that hasn't been covered in this discussion, we are more than willing to answer your questions and we will be sharing resources for further work on this as well.
I actually have a question for Hussan if nobody else has a question. Just back to the directives. I know that speaking of tensions, that there's, you were saying that one way that we can keep it in place is if we, keep fighting for it. But I've also heard kind of the opposite, that the reason that it's still in place is that it hasn't been publicized so much and people don't know about it. Obviously, that causes a lot of problems for access when people go to hospitals and hospitals don't know about the directives, and that they should be providing care to people without health cards. But what is your take on how much things should be publicized with knowing that there might be a political backlash if lots of people find out that this is happening, and might they say, oh no, we actually don't want to be doing that. We don't have the money for that, scarce resources and all of that,
I mean, I think this was tested, right? So for the first year the first year and a half when the director was in place, we were hearing actually almost entirely only from doctors and health researchers that we shouldn't publicize this. And then, as sort of 4 months ago, it came under threat. And then 1,000 doctors wrote this letter. They got a lot of media, a lot of pushback, and there was a direct impact. The cancellation was taken off the table. So I think, we've tested this hypothesis, and we have seen that when we publicize, we can defend it. I think that's true most of the time. I think that in terms of the conservative government, or I say a liberal government, right, like, or actually either government, like the framing is, you did a right thing, congratulations, keep going. And I think that that's hard for people to swallow because in terms of political messaging, we are more used to criticizing and attacking, often after the fact. So in this moment, so it's not just like, should we publicize it, is how to publicize it. I think like any government, the Ford government is interested in being celebrated and have their, being told they did the right thing. So it's a question of, these decisions are not being made about money, like, for example, the education worker strike that's happening in Ontario, it's not about money, it's not about the wages of the workers. It's about the politics. So at that level, very few decisions are made on budgets. So I think as long as we are able to keep talking about it, it will stay. And if it doesn't, because we keep talking about it, we could maybe in a future government actually fight for it. Otherwise, it just gets buried under the rug as something that was COVID specific.
Thank you.
Okay, so thank you both very much. This has been very enlightening and extremely interesting, and I hope that everyone who has attended today has something that they can take with them into their own work and continue pushing for access to human rights and health, access to health. I'm hearing also a lot about the importance of collective action, and we've heard also about the effectiveness of collective action with all of the recent changes that have come about in positive ways for migrant workers. So thank you again to our panelists, Monica Gagnon, thank you, Paglingayen, and Syed Hussan. And I'd like to thank everyone who is attending virtually as well. We have many exciting things coming up, including the second opportunity to take a new online course for frontline workers on research literacy. Details about this are available on the Wellesley Institute website, Community Knowledge Program. The URL for that is wellesleyinstitute.com/community-knowledge-program. And please, Hussan has asked that we sign and share the migrantrights.ca/take-action/permanent-resident-status. And you can go to migrantrights.ca and find a link. For more on our upcoming course and for access to our needs assessment and resources from our previous events, please keep up with us by signing up for the mailing list. If you aren't already on it, you can do so by filling out the form on the webpage. Thank you very much for attending, and we hope to see you at a next event. It's been my pleasure and my honor to host the discussion today. Thank you very much, and we look forward to continuing to connect with you.